Hi everyone, I'm Skiff from YINGCHI, and I'm sure that Dr. Jepo has shared a lot and whether the experiences and the effect of TMS he has viewed. And personally, I have learned a lot from Dr. Jepo, and I want to share some theories and applications from researches and progresses of TMS used in neurology with you. And you can follow YINGCHI's social media, and you can subscribe the YouTube channel to see the lectures. And today's lecture will also upload to the YouTube channel. So first, we will have an introduction to TMS, and then we will go over some international progress of TMS in neurology to see its applications worldwide. And the most important part for our lecture today is the application cases of TMS in neurology. And then we will review of the effective TMS protocols from whether the guidelines or the experiential protocols. And then we will have some recommendation to the powerful YINGCHI TMS. And first, so what is TMS? It applies a time-verifying pulse magnetic field to form an induced electric field in your brain, which generates induced currents. And thus, the brain tissue and its neurons inside the skull is stimulated. And the whole process is non-invasive and painless. So TMS is one of the 4 brain science and technologies in the 21st century, and it has been approved as early as 2002 to use for refractory depression. So TMS has many frequently used methods. So for diagnosis and prognosis, we use single pulse TMS to test whether the motor threshold, the central motor conduction time, and we use single pulse TMS to evoke the MEP. And in clinical practices, we will use rTMS and TBS. So rTMS is the conventional TMS protocols, and it is widely used in clinical practices. And for TBS, which is an optimized protocol of rTMS, and it is approved by FDA in 2018. And we also use the sham TMS in basic and clinical researches to ensure accuracy and effectiveness of clinical researches. And this is YINGCHI sham TMS. And so TMS has many applications in many fields, and today we will be only focusing on the applications in neurology, and we have already done the applications of psychiatry and pediatrics. And so TMS has been approved by FDA as early as 2008 for depression, and then there are many applications of TMS in many fields. And in 2013, rTMS is approved by FDA to use in migraine. So next, we will introduce some international progress of TMS in neurology. So here is the evidence-based guidelines on the therapeutic use of rTMS in 2019, and it highlighted that rTMS can produce significant clinical improvement in various neurological and psychiatric disorders, and we will also have a summary of the recommendations from these guidelines. So these are some Chinese expert consensus of TMS, especially for Parkinson disease and disturbance of consciousness and migraine. So TMS has been applied a lot and widely in China for many years. And TMS also have a guidelines for pain treatment research, which is published by the International Association for the Study of Pain. It has many recommendations and has standardized the procedures for the TMS used in pain. And today we will not focus on pain in details, and we will go over for the TMS used in pain department in next week. And next comes to the applications of TMS in neurology. So for TMS use in stroke, and stroke is a medical condition in which poor blood flow to the brain causes cell death. And there are two types of stroke, the ischemic stroke and the hemorrhage stroke, and they have different causes. And we have divided stroke into three important stages, which is the acute stage and the subacute stage and the chronic stage. And we do not include hyperacute stage here because it is not the main focus. And stroke do have some signs and symptoms. For example, that patients may be unable to move or feel one side of their body, and they may lose of vision to one side, and they may also have some problems understanding or speaking, and these symptoms can be permanent and will causing some long-term complications like loss of bladder control. And stroke is the second most frequent cause of death. And in 2015, there are more than 42 million people had a stroke and were still alive. And 11% of them, which is 6.3 million deaths. And overall, half of people who have had a stroke live less than 1 year. And 2/3 of stroke occurred in those over 65 years old. So here has the important functional recovery model, and we need to consider the TMS protocols according to these models. And first is the interhemispheric competition model, which means that here the two hemispheres has a competition relationship that when the affected hemisphere decreased its excitability, the unaffected hemisphere will increase the excitability of it itself. Thus, it will cause some more inhibition to the unaffected hemisphere. Thus, the transcallosal inhibition is increased. So to consider about the interhemispheric competition model after stroke, the balance between the two hemispheres, especially for the inhibition, is broken, and that will affect the recovery of limb function on the affected side. So we may apply high-frequency rTMS or ITBS, which has an effect to excite the excitability of the epithelial M1, or we may use a inhibitory TMS, which is the low-frequency rTMS or the CTBS or the contralational M1 to induct the excessive interhemispheric inhibition from the unaffected hemisphere. That's to help in the recovery of the limb function. And for the patients, especially the severely affected patients, the interhemispheric competition model has been questioned for women using high frequency to excite the affected side has little effect. So we may suggest the vicariation model. So this model postulates that the function of the unaffected hemisphere compensates for the impairment of the affected hemisphere, which presents an adaptive effect. So when the recovery potential of the affected side is limited, the vicariation model of the uninhibited limb is beneficial to the recovery of the motor function. So we may apply high frequency or ITBS over the contralational M1, or we can inhibit the excitability of the epithelial M1, but the high frequency is used a lot. So here comes to a conclusion that the degree of neural pathways and connections retained after stroke is important. So when the retention is relatively high, the interhemispheric competition model dominates. So we may apply high frequency or ITBS on the ipsilational M1. So when the retention is relatively low, especially for those patients who are severely after stroke, when the variation model may dominate, and we may apply high frequency or ITBS over the contralational M1. So here is a literature case of rTMS used on the leg motor area in the early phase of stroke. So this study has acquired 21 patients, and they have an average of 11 days post-stroke. So their results is assessed before and after the intervention. They use a Debicon coil with a high frequency over the leg motor area. As you can see the results compared to the sham group, the high frequency rTMS group shows a significant improvement in the lower limbs and a greater improvement in the AMBS2. So here we come to a conclusion that the high frequency rTMS over the bilateral leg motor areas has potential to be a new rehabilitation therapy. So for the AD, which is a neurodegenerative disease, starts slowly and progressively worsen, and 60 to 70% cases will develop to dementia. And the most common early symptom for them is difficulty in remembering recent events. So the advanced symptoms for them may be some language problems, disorientation, including easily getting lost. They may have some mood swings, loss of motivation, self-neglect, and when it comes to an advanced stage, they may have bodily functions are lost, ultimately leading to death. And the typical life expectancy following diagnosis is between 3 to 9 years. So AD is the most common neurodegenerative disorder around the world. And in 2006, the world population so the absolute number of the AD patients is more than 26 million people, and the absolute number would quadruple by 2050. So here comes to a literature case for TMS and combined with cognitive training intervention in AD. And the treat will last for 6 weeks, 5 days a week. And this uses multiple targets. 3 out of 6 brain regions are stimulated in their daily treatment. They use a figure-of-8 coil with high-frequency rTMS. And as you can see, the results compared to the sham group, both the PE group, which receive at least one active treatment, or the PP group, the no protocol violations and meeting the minimum required number of study sessions, has acquired better results compared to the sham groups. And thus we can draw a conclusion that low-risk therapeutic benefit for patients with milder AD. And the effects of TMS is beyond the pharmacological SOC. For Parkinson's disease, it is also a degenerative disorder of the central nervous system, and it is a long-term disorder. And the main effects is on the motor system. The patients may have tremor, rigidity, slowness of movement, and difficulty with walking. And they may also develop other problems, such as depression, anxiety, and they may also have some problems of sleep and sensory systems. and in a more advanced stage, the patients may develop to Parkinson's disease dementia. And the major pathological changes is the diminished substantia nigra, leading to a deficit of dopamine. And PD is the second most common neurodegenerative disorder after AD, and 7 million people globally has been estimated to affected by PD, and 4% of the population over 80 go over PD. So there are many new cases per year. And the potential mechanism of TMS on PD may because of RTMS can modulate motor cortex excitability, and a high-frequency RTMS may improve the slowness of movement, and a low-frequency RTMS may reduce oxidative stress or improve dystonia. And we have mentioned before that the deficit of DA is important to PD. So some people may take levodopa, and it may cause some levodopa-induced dyskinesias, and TBS can help in LIDs. So you can see in this graph that the cerebellar CTBS can help in levodopa-induced dyskinesias, or a low-frequency RTMS over M1 area or SMA area. And TMS can also work on to affect the production of DA in the substantia nigra striatum. To use a high-frequency RTMS over M1 or DLPFC to increase the release of dopamine. And here is a literature case of RTMS used for the motor symptoms of Parkinson's disease. And their results is evaluated, their clinical evaluation starts from before the TMS treatment and 1 week treatment, and 1 month to 6 months after treatment. And they use a figure of 8 coil to apply high-frequency RTMS over the bilateral M1. So you can see that the M1 RTMS has showed improvement in the results for rigidity and bradykinesia, which is the abnormal slowness of physical movement. So this is another literature case for the left DLPFC RTMS on depression for Parkinson's disease. And there are 22 Parkinson's disease patients with mild or moderate depressive episodes, and they're evaluated before the TMS treatment and 1 day after the treatment, which stands for the short-term results, and 30 days after treatment session ended to see the long-term effect. They use a figure of 8 coil to stimulate the left DLPFC with a high frequency. And we can see the results. So this white square stands for the real stimulation group. And we can see that the depression rating scales after 30 days has reduced a lot. And we can draw a conclusion that TMS has a beneficial effect of high frequency over left DLPFC in PD patients, and these results can lasting at least 30 days after treatment. So this is a case, and this is the protocols from Professor Zheng Zhong from West China Hospital. And this is an old lady, and she has a son, which is he is in his 30s, and both of the two has Parkinson's disease, and the old lady has Parkinson's disease for many years. And for the dyskinesia, which is some problems in their motor function, the Dr. Zheng Zhong has used high frequency over the bilateral M1. For tremor, he uses cerebellar low frequency RTMS. And for depression and a bad temper, the Dr. Zheng Zhong uses a high frequency RTMS of the LPFC. So let's see the results before and after TMS treatment. So you can see that the results is obvious, and we have more experiential protocols from Dr. Zheng Zhong, and we will share with you in the fourth part. So here is a literature case and of the application of low frequency RTMS for the treatment of epilepsy, and the whole treatment lasts for 2 weeks, and the use of a figure of 8 coil over the epilepsy focus with low frequency. So as you can see, compared to the low intensity group, the low frequency RTMS with 90% of RMT has shown a significant anti-epileptic effect on patients with refractory partial seizures. And RTMS can really reduce the intervertical epileptic discharge frequency and also improve the psychological condition of these patients. So TMS can also use in multiple sclerosis. And here are 19 patients with relapsing remitting multiple sclerosis and lower limb spasticity. And they are treated for 5 days a week, a total of 2 weeks, uses a high frequency RTMS via figure of 8 coil over the leg motor area on the contralateral side. So this is the S2 stands for the end of the last stimulation session. And as you can see, compared to the sham group, the 2-week RTMS has a significant improvement of lower limb spasticity, and the clinical improvement was long-lasting and lasts for at least 7 days after the end of treatment. So we can draw a conclusion that RTMS may improve spasticity in multiple sclerosis. So TMS can also use in migraine, which is also approved by FDA. And migraine is a primary headache disorder, and it is characterized by recurrent headaches from moderate to severe. And the episodes affect one side of the head, and it lasts for a few hours to 3 days. And associated symptoms including nausea, vomiting, and sensitivity to light, sound, or smell. And 1/3 of people affected by migraine have around, and it means that a short period of visual disturbance signals the occurrence of migraine. And many people has been affected by migraine around the world. As you can see that more than 40% of women in United States has been affected by migraine. So here is an application to use a high-frequency rTMS in migraine and over the LDL-PFC. And as you can see the results, compared to the sham TMS group, the rTMS group has achieved significant effect, and both in the headache frequency, in the severity, in the analoglosis, and the functional impairment. So we have drawn a conclusion that the 10 Hz, which is a high-frequency rTMS in migraine, is effective and safe. So TMS can also use in chronic neuropathic pain. And in this study, it has used a figure-of-8 coil with high-frequency rTMS over the contralateral motor area. And the total treatment time lasts for 9 days, and the results is obvious that more than half of the patients significantly relieved from the pain. And they have recommended that patients with a pain history less than 5 years can benefit significantly. And they have drawn a conclusion that earlier rTMS treatment may be better. And TMS can also be used in chronic primary insomnia. And they have, in this study, they have compared rTMS with medication and psychotherapy. And here they uses a figure-of-8 coil with low-frequency rTMS to stimulate the right DLPFC. And as you can see, compared to the medication and the psychotherapy, rTMS group has shown a significant result, and the relapse and the recurrence rates after 1 month of the treatment, the TMS has shown the lowest relapse rate and the recurrence rate within 3 months. And thus we can draw a conclusion that rTMS can improve the sleep architecture and improve their body weakening level, and the long-term treatment effect can be guaranteed. So here are the review of effective TMS protocols, and this is the recommendations from the evidence-based guidelines. And these are some recommendations from the Chinese expert consensus of TMS. And these are some protocols from some international guidelines, consensus, and literatures. And here is the experiential protocols from Guo Yi, and he is from the Shenzhen People's Hospital. And this is also the protocols from Shenzhen People's Hospital. And these are protocols from West China Hospital and edited by Dr. Zheng Zhong. So this is Shenzhen People's Hospital. They have an annual outpatient volume of more than 100,000 patients for their Department of Neurology. And this is Dr. Zheng Zhong and West China Hospital. They have many years of TMS treatment experiences, and they have more than 150,000 TMS treatments. And this is Dr. Zheng Zhong helping a girl with aphasia, and this is YINGCHI TMS used in West China Hospital. So here comes to the recommendation from YINGCHI TMS. So for TMS, machine. It may need to have a powerful, high power, and to need a modern design and ergonomics. So for the stimulator, it has a large color screen to show the parameters and the working status. And it also have 5 predefined treatment protocol buttons, and you can choose one of them directly and effectively. And it also have a strong cooling system. So why we need a cooling system is because when the coil is working, it will cause overheating problems. So YINGCHI is the only TMS manufacturer with both air cooling and powerful liquid cooling technologies, and this system is optional. And this super efficient cooling system enables daily intensive treatment with a large patient's flow, and it also has overheating protection, and it has automatic system shutdown. So when the temperature passes the safe limitation you have set it will automatically shut down. And we also have a quick after-sales service and efficient training for TMS use to guarantee the safety and efficacy. And as for the coil, we also have many unique designs. So first, the coil needs to be lightweight. So for the patients and for the doctors to easy to handle and easy to apply on the patient's head. And as you can see here is the LCD screen, and it has intensity adjustment buttons. So it is easier for doctors to test or measure the motor threshold. And it also has a pulse calculator, and it can monitor the remain pulses and to guarantee the lifespan of the coil. And as for the coils chosen for neurology, the flat figure of 8 coil is widely used, and it is well focused. And conventional coil used for depression treatment and other neurological diseases. But for the angulated or the double cone coil, it can focus deeper stimulation, and it has an ergonomical shape design. So for the depth of the double cone coil, it can stimulate a depth of 4 centimeters, and it can induce a higher and wider spread electrical fields that have better ability to stimulate deep brain surge regions. And so why we need a better design for an ergonomical shape, it can have a better contact onto the brain, and it can achieve deeper stimulation, so it can help the patients to benefit earlier and hurts less. And this coil also has less noise, and it is lightweight, easy to use. So for the effective of double cone coil, it can achieve a well balance between the depth and the efficiency. So make it possible to induce motor potentials of the lower limbs for diseases like stroke. And with its ability of bilateral stimulation of the leg motor area under high frequency, the double cone coil can effectively promote the functional reconstruction of the leg motor area, thus help recovery the motor functions in certain degrees. And for those experience treatment tolerability issues at high motor thresholds, the double cone coil could reduce scale pain. For the double cone coil can induce an effective magnetic field at depth without increasing the electrical field intensity in the superficial cortical regions. So these are the true efficiency and the true feedbacks from our users. And let's see a video about how double cone coil used to evoke motor evoked potentials from the leg motor area. So as you have seen in the short clip, that only of intensity of 35% of MT can successfully evoke the leg motor evoke potential, and compared to the normal coils which cannot induce motor MEP of the lower limbs. And the depth of double coil make it easier to induce MEP of the lower limbs, and in addition to the leg motor area, the double coil can also stimulate like ACC and other deep brain areas to achieve better results. And this is true feedbacks from people, customers use double coil, and they have already used double coil in schizophrenia, tinnitus, OCD, and other neurological diseases like rehabilitation for stroke. And they have all applied that a double coil can help the patient's benefits earlier, and it has a better contact to the patient's brain. So these are the references that I have no space to attach to the corresponding page. So thanks for your patience and thanks for your listening.